think we will get started, Kerrin. Thanks so much. I'll just welcome everyone online. Thank you very much for joining the Statewide Biobank seminar today, and we're very much looking forward to hearing from Dr. Kerrin Bleicher, who's from the Sachs Institute, and she's going to be talking about the 45 and up study. Just to give you some background to Kerrin, in addition to being an ocean swimmer, I've just learned, which is very impressive, Kerrin is an epidemiologist, so she obtained her PhD from the University of Sydney, and she worked as a clinician for over 20 years before joining the Sachs Institute, actually this year, as Director of Research Assets, where she is overseeing and leading the 45 and up study and its teams. And Kerrin's responsible for the ongoing development of the 45 and up national research resource for building engagement with participants and partners and policymakers and fostering collaborations. And of course, the Statewide Biobank is very pleased to be one of the collaborators with the 45 and up study. And so in her previous role as head of the Australian Institute for Health Welfare, I think primary health network.
It's a mouthful.
It is, but that's all right. She worked closely with stakeholders to fill data gaps and support organisations to meet health needs of local communities. And she's also worked as a data analyst and a researcher reporting on health service performance. So Kerrin, it's really wonderful that you're able to join us today, particularly after a bit of a hairy weekend. Yeah, we're very grateful for your time and very much looking forward to you telling us more about the 45 and up study and the biospecimen insights around that study.
Thank you very much, Jenny, and welcome, and thanks for inviting me to speak. And certainly the collaboration with the Statewide Biobank is a very important collaboration as we look forward to increasing the sort of genomic data as well as the phenotype data and the lifestyle information and the wealth of other health service research data that we have that goes alongside the 45 and up study. So just a little bit of background. I'm not sure how many people know much about the 45 and up study, but in essence, they're started in 2006 and used the Medicare framework and invited nearly everyone in New South Wales who was over 40 or 45 and over to join the study. And between 2006 and 2009, the study had gathered 267,000 odd participants, just a few more than that, and it's been so ongoing now for 15 years nearly for some of the participants. But follow-up surveys are sent every 5 years. Participants have agreed to have their data linked to enable researchers to follow their health over time. And they also consent to allowing us to invite them into other studies, which we call sub-studies. And I'll talk a little bit more about that later. So the study has been routinely linked to a wide range of administrative data sets, and we do continue to explore new linkages. And just most recently, with all the COVID work that we're doing, we're looking at, and well, we've applied to link to NSIMS, so that's the Notifiable Conditions Information Management System, and also to the new COVID data sets. And that's going to really support long-term research into people who do get COVID, and that may end up being genomic research, although I have to say we don't have many cases, luckily, in New South Wales at the moment. But it will allow looking at long-term outcomes for those people. So as part of the waves of follow-up, so we call them each time there's a new survey go out, and we're up to the third one now, and that went out in July this year, and that included supplementary questions around COVID, actually 4 pages of it, and that went out to 85,000 participants. So to date, they've had a huge amount of use of the resource, and it is a resource, a 45 and up study. So had over 150 projects, over 750 researchers have used the study, and they sit across 90 organisations. I think there've been over 370, getting up to 400 research papers published in, and many of them in very high level journals. So it also supplies a lot of information to policy agencies, and I think there's 30 policy agencies that get 45 and up data. So the Sachs Institute is expanding the value of the resource, and I'm talking about 45 and up as the study as a resource because it is available to all researchers, as I mentioned. But this extension is around linking biospecimen collections. And the purpose of that collection is to facilitate, the population health research, the multi-omics research, and perhaps also some other biometric research with that. And by doing that, we're building an open access collection of blood samples that are linked to all the data within the 45 and up study. So what value does 45 and up bring to omics research and multi-omics research? We've got 15 years of longitudinal data from the 3 surveys, as I mentioned, and this covers broad health and social topics. It has information like participants' behaviour, their experiences, their household and demographic situations, carer responsibilities, relationship changes, psychological distress, quality of life and chronic conditions information. And by having the 15 years of survey data, you can track longitudinally how things are changing over time. But as well as having the 15 years, we link the data and that joins a lot of dots. So even if people drop out of the study, there's always the data linkages. And at the moment we've got, most commonly there's linkages to Medicare, to cancer registries, to other disease registries, cancer screening data, and typically, of course, the hospital, PBS, MBS, other health data sets, ED, New South Wales mental health ambulatory care. They're the key ones, I think, that we link to all the time. And we do have a master linkage key, so it does make linking to all the New South Wales data sets very easy, and of course that's done with Cheryl. But we also link to Commonwealth data, so I mentioned MBS and PBS, so we do that linkage in-house, and we provide that to researchers when they've got an approved project. And but there are other data sets. We're at the moment getting the aged care data, and that's coming from AIHW, and there's National Death Index with cause of death data that's also available nationally, as well as the local, state-based death data. So that's the linked data. I guess one of the huge advantages of 45 and up are the large numbers in diverse cohorts. And 45 and up was not designed to be a representative study. It was designed to ensure that there were enough people in cohorts of interest for research, especially into health and ageing. So we've also got large numbers of groups from Aboriginal and Torres Strait Islander people, and we've got an oversampling of people living in rural and remote areas. Sometimes people, I think, wrongly say that the demographic group is perhaps a more well-heeled, healthy group, but this is not true. We've got, say we've got 2,000 people living in social housing. We've got really broad numbers of culturally and linguistically diverse. I think it's around 30,000, but I can show you some numbers shortly. The other great advantage of 45 and up, which is you can do you can do your own sub-studies. Now what that means is that you invite a group of participants into an ethically approved interventional study or a biospecimens collection or a bespoke survey or a combination of those things, and then we can select cohorts of interest that can optimise those research needs. Another advantage is the ever-growing relevant data, and I mentioned that we'd added COVID questions in, which was actually increasing the survey by 50% to really have cutting-edge questions around the impact of COVID restrictions as much as people's exposure to COVID in that most recent questionnaire. And of course of interest to all of you are the biospecimens collections, and so the survey and data linkages enable researchers to select biospecimens relevant to their research and to explore interactions between the phenotypes and genotypes, the lifestyle factors, medication and other treatments, and also account for social determinants of health. So the data linkages are ongoing, as I mentioned, and the surveys as well, and they will enable the researchers to look at participant outcomes many years into the future. So it's also possible to do approved research to build a sub-study with a specific questionnaire to accompany a new biospecimen collection, and that's happened quite a bit in the past already. So another area that may be of interest, I'm not sure with biospecimen research, but is the specific local geographic area data. So to get local geospatial data and be able to accurately analyse catchment areas, and that could be related to the environment or pollution within catchment areas, or it might be around health service access. But having that geospatial data, local area geospatial data available, can actually really add to the accuracy and the ability to explore geographic variations in health outcomes. And lastly, expert support, because the team and something that's really important to us at 45 and up and SACS in general is knowledge translation. And we do have advisors in-house to support researchers to achieve a greater impact from their research. And we want more people to use that. So always happy to talk about how do you get more impact from the work that you're planning to do, and it's always good to have a chat about that up front or during your project, of course, as well. So what I was hoping to get out of the session today is, obviously I want to share the exciting 45 and up research opportunities, but really importantly, I'd really love to get your feedback on the barriers you need to overcome to do your research and see how we might be able to support that as we planning for the future with our biospecimens collection. So getting feedback for future collections, it's thinking about topics of broad, the broad questions that you're trying to ask that maybe not so easy to get the data or maybe take many years to collect those biospecimens to do that research at the moment. And the populations of interest, are they people who've had cancer? Are they healthy populations? Are they rare diseases? We can always, because we've got that triangulation or multi-angulation of all those different data sets, we can identify groups that you wouldn't normally be able to pick up, or you can just look at a general population, and that's one advantage of 45 and up. And so I'd love to know how can we fill your gaps either now or in the future. And we're also interested in partnerships, and so that's something that if people are interested in, let me know. So just a little bit about our current biospecimen collection. So we've had 3 major collections, and there's one just about to go in the field, which is the neurobipolar study. But since 2009, we've had the Link Up study, a skin health study, which was sponsored by Cancer Council, and Link Up pathology. And this table here just gives you some idea of the measures that were collected. So I mentioned that you could do your own bespoke questionnaires or collect some other biometrics data. So for example, with the Link Up study, the height, weight, waist circumference, blood pressure and heart rate were collected at the same time the biospecimens were collected. And they had a questionnaire as well, also asking about self-rated health and recent health events. So the tubes that were collected were the EDTA, ACD and lithium heparin. And then the biospecimens are processed, and for that one it's plasma buffy coat and red cells. But you can see more in the more recent collections. In the Link Up pathology, we've got the serum, the whole blood DNA and PBMC. So we want to keep improving the collections, and of course there are many options now about how to go about that. So that's what I'm hoping I'll get some input from you from. So as you can see there, we've got storage -80, but then for the new DNA and PBMCs, they're at -190 degrees centigrade, and they're stored at the Biobank. Oops, I lost my mouse, sorry. So just at the moment, we've collected data from about 2% of the cohort, but there's huge potential to have a much larger collection. And just showing you what we have got at the moment with the nearly 5,000 biospecimens. So 45% male, mixed ancestry, although, you know, the British ancestry is predominant there. And when people fill in their ancestry question, that's a self-reported question, and they can fill in multiple ancestries, of course, because most Australians have multiple ancestries or ancestors from multiple places. So we specifically left out Australian because, of course, that had the largest one, but we took, unless they were Aboriginal and Torres Strait Islander, we didn't record Australian in that little summary table I've got there. But just to show, you know, it's quite a large European group, smallish Asian group, and even slightly smaller Aboriginal and African cohort. But we have full details, so we can mix groups because a research at the moment was interested in ancestry and looking at particular people from particular areas. And of course, with only 2% of people included, so with those, I just say the percentages there, that's actually of that group, but overall, doesn't matter if it's British, European, Asian, African, it's about 2% of the 45 and up cohort that we've got data from. So there's another 98% of each of those groups that can be collected from. So if you can work out the numbers pretty much from that. So age of biospecimen collection, majority were between 60 and 79, and obviously people are aging and those specimens being collected over time. So the next one down, age as of this year, gives an idea of the current age groups for the people who we have biospecimens collected from. So within those collections, there's nearly 458 people who've got self-reported diabetes, 174 who've had a stroke, and that was at the time of when this was done, which was probably, I think this was reanalyzed based on 2019 data, so that was as of last year, and 840 with heart disease. So the future, potentials to collect from vulnerable populations. So this is just more broadly, who's available to donate biospecimens. And as you can see, there's just over 1,300 people from Aboriginal and Torres Strait Islander background. There are 38,000 aged over 80, 28,000 from non-English speaking background. Outer regional remote areas, you've got just over 20,000 if you combine those groups. Socioeconomic disadvantage, so 37,000 from more disadvantaged areas. And those with chronic conditions, so 42,000 who've had cancer, 32,000 heart disease, asthma, diabetes. You can see the numbers there. We also collect validated measures in the self-reported questionnaire of mental health, so using the K10. We've also just added in, although this may not be so useful for you, but the loneliness scale in the latest questionnaire. So how do you use 45 and up? I think the first thing is to call us and go, does this sound feasible? This is what I would like to do. But otherwise, you can go online if you're really sure of what you want to do and you're confident we can support that research. There's an EOI on the website, and that's on the SACS website, and you're going to see the researcher for researchers, and you'll find the link to their expression of interest form, so you can fill that out. I've got the 45 and up research team email in there. And then you go, once you've had a chat to us or put in your EOI and then had a chat to us, then you develop your protocol. So that's the next step then, is doing the approvals, getting the approvals, and approvals need to come from 45 and up. Engaging with the New South Wales Biobank as well, and your local ethics. Then the third step then is the collection. And just letting you know, the 45 and up team identify the cohort, they prepare the invitations, they work with you and New South Wales Health Pathology and New South Wales Biobank, and they liaise with all the participants. So all that work is done. To get costing, there's also, costing really depends on how big your study is, because it depends on how many people you want to post invitations out to, or email them if you want to use email. That's obviously not so expensive, but the costs, you know, we're a not-for-profit, but we cover all the costs of running these studies. And as you know, it's quite expensive to do biospecimens research and to collect biospecimens. So that will all be built in, but we are, as I mentioned, a not-for-profit. So I did want to talk about, can I, before I talk about the next one, does anyone have any questions?
I did have one question. It's Craig Getty here.
Hi.
So you mentioned that there was a variety of different people who were consenting to biospecimen collection. Was there any difference in the fraction of people depending on their heritage? We've noted that there can be some real sensitivities in Aboriginal and Torres Strait Island populations for collections. So were they underrepresented? Were they less likely to respond?
That's a really good question, and we're just in the at the moment analysing the latest pilot program. So I was going to have a chat about an early program which was called Link Up Study, and the latest is Link Up Pathology. But I think maybe we should put that in. I think that's a really good question. No, the answer is at this point in time that hasn't been analysed, but I can put it on the list to add into our queries around this latest study, and then I'll let you know.
Thank you.
Yeah. Any other questions at this point in time? No? Okay. So this sort of leads on to Craig's question then, and it was around, well, there was a study done called the Link Up Study. So this was the one done in 2009, and it set out to try and look at who's donating, how do you maximise the response for participation, how can we inform future collections going forward. And so this paper, which you can access, it's open access online, and it's by Emily Banks, Nicole Herbert, Chris Rogers, Tanya Mather and Louise Jorm, and it was a randomised trial investigating the relationship of response rates for blood sample donation. And they looked at, I'm going to go into it, but they were interested in fasting, and they were interested in, they're interested in fasting, collection site, and something else which I was just my reminder letters. Sorry, that was the other one, whether a reminder letter was sent. So it was quite a, you know, it's a quite focused study, which it needed to be. And with this, the next pilot that's gone out was not a randomised trial, and we can probably explore other observational reasons for response, but this was actually a randomised trial. So just letting you know a little bit about this, there were 2,340 participants invited to participate. There was a regional group, that was the group from Wagga, and an urban group, that was the Parramatta group. They're either invited, they're randomised to attend either a dedicated clinic or a commercial pathology clinic. And within the dedicated clinic groups, participants were randomised into a fasting group or a non-fasting group to see if that made any difference. The fasting group had to get an appointment early, so they didn't actually have a fasting group in the in the commercial pathology areas, because they couldn't ensure that the participants would be able to get an early appointment. So in Parramatta, a reminder letter was sent after 2 weeks, and then no reminder letter, to see what the difference was there. So what did make a difference to the response rates? We've got 33% overall participation, I think the researchers have been hoping for 50%, but in fact 50% was probably very hopeful, very optimistic, and actually 33% was, I think, a rather good participation rate overall. Interestingly, there was no difference for fasting or not fasting, and it didn't make any difference if you sent a reminder letter or not. I think they got an extra less than 1% when they sent out the reminder letter. So that was not, in this case, a worthwhile use of funding. There was a much higher response rate, as you can see in that those couple of slides there from the regional areas. So Wagga, 41% response rate, and Parramatta was 26% response rate. When you had a dedicated clinic, I might just describe the dedicated clinic. So these were clinics that were established specifically for the trial, and they had an appointment time. So when the participants were sent an invitation letter, they got a time in that for their appointment. And then the staff of those centres would call the participant 1 to 2 days before and just to check that they're all right for their appointment. And if that didn't suit them, they would reschedule another appointment. The other difference about these dedicated clinics was they were open Sunday to Thursday, so there was an ability to donate blood on the weekend. In contrast, when the existing local commercial pathology centre was used, appointments were not given to participants, and instead they're asked to attend at a time. Sorry, excuse me. And they were asked to attend at a time that was convenient for them. And they did have a 4-week range of which to attend the clinic. If they hadn't been, then they got sent a reminder letter that if they didn't come within the first 2 weeks. So within the dedicated clinic, participants were randomised into the fasting or non-fasting, and but they didn't, as I mentioned, they didn't do that in the commercial centres. So when we look at these results here, when we look at regional and the urban areas, they've been aggregated, so it didn't matter whether they're in the fasting or non-fasting reminder or non-reminder group. That was the regional participation versus the urban participation. And as you can see, the dedicated clinic, 38% response rate versus 25%. So they're really significant differences in the response rate. However, I guess everyone's always interested in what's the response rate, but what's the extra cost in getting that higher response rate? And I think that's really important to consider. It turns out that the response rate, the cost of the dedicated clinics was about 40% higher for every participant who actually did participate, and it was 110% higher overall. So those dedicated clinics had 5 staff. They had the phlebotomist, they had 2 other, they had a program organizer, and they had 2 other staff. I think that was it, maybe 3 other staff. So they were really expensive. And I think that's definitely worth considering, even if the response rate's not so big. Are there other ways to, by not having a dedicated clinic, what are the other ways that can increase response rates? And I think there are lots of options, because this was really narrow to test these particular factors. It didn't do advertising, or there was no media, social media associated with this study. And so there are other ways to think about increasing response rate. But I do think it's worth considering, the phone call. Are there other, phoning someone to remind them about their appointment has been shown to increase response rates. Having assigned appointment times might be something to consider in future studies to increase response rates. And maybe they could happen, they don't have to be in an assigned place. Just to let you know, those dedicated clinics, one was in the RSL club in Parramatta, and in Wagga it was in, I think, the police service club and a youth club. So there were sort of local spots that were well known. But without going through the process of setting up a dedicated clinic, there might be other elements of those particular clinics that are worth considering if you're going to do a study and you want to get the highest response rate possible. So Speaking of doing studies, so with 45 and up, you can create your own sub-studies, and there's a skin health study that's been done, so that was sponsored by Cancer Council. And what happens when people are doing their own sub-studies, they get a collection of blood that goes to wherever they want to store it and their research, but they also collect additional blood that then goes into the 45 and up program, and that's stored at the New South Wales Biobank, and that can be used for other research. There's a study coming up, as I mentioned, the bipolar study, and so we have identified people who are likely to have bipolar, and they're the cohort being chosen for this study. There's also been an inquiry lately about dementia studies, because there's interest in dementia biomarkers. And another sub-study that we've been discussing is around saliva collection. But whichever way, or if you've got ideas and you want to do a sub-study, then speak to 45 and up team to discuss the feasibility. So I really would like to open the field for questions and discussion at this point, and I can't see any of you online, which is a bit disconcerting, I must say, speaking to my computer, but I hope there's some interest in what I've been talking about, and I'm hoping that you might be able to share with me some of the barriers that you need to overcome to do your research, or you need overcome to do your research. Where can we help with those? Are there particular populations? What are the priorities for future collections? How can 45 and up fill the gap, either now or in the future? So would it be all right if we just open to the first one, the barriers to overcome research?
Sure, Kerrin. Now, I know it's a bit strange, isn't it, sort of giving a talk to a computer, but I suppose we've been doing this for a little while in the biobank, and it seems to work pretty well. So, people can either put questions into the chat or raise their hand or just jump off mute and make a comment, I think. So any of those things will work well. I guess just the question of barriers that you need to overcome your research, it's a bit of a different, like I think almost everybody on the call might have a different kind of barrier. But I guess just in a general sense, I think it's interesting that, the 45 and up cohort was, obviously largely recruited well before COVID, and now we're in COVID. I think a lot of the barriers in terms of recruitment of people to research have probably changed just over the last 4 or 5 months. And I'm actually kind of writing a paper about that, so it's a bit frontal lobe kind of thing. What do people think about that? Like, is that something that's really changed recently, or there's always been particular barriers that are still problematic?
I mean, sorry, go on.
Oh, it's great getting here. So, generally research is barriers, right? It's just, one barrier after another. The obstacle is the path. I think the interesting thing that we're seeing is we're starting to see lots of research that looks a bit like 45 and up. So people are looking at those kinds of linkage connected programs that try and bring populations together. The question I guess for me is, is 45 and up in a position to embrace new populations and recruit different groups of people for very specific kinds of projects that might then, again, like the biospecimen collections that we do, be repurposed for a more population-based research. That would be sort of one of my questions about how it might fit, and then how that might overcome some barriers.
Okay, that's an interesting question, and one that's actually been quite hotly debated as part of our strategy moving forward. So I don't have an answer to that yet, but it certainly is on the agenda. Are there specific populations that you're thinking about?
So we're starting to see that people undertaking acute care for not necessarily community dwelling populations, but people who have contact with tertiary institutions for acute care. We're more and more interested in seeing what's happening with some of those high cost treatments. Particularly we end up, well, as an oncologist, we end up getting a clinical trial that has extraordinarily tight conditions, and then they spend as much on the sales reps coming out to tell us how drug X is useful for everybody, not just the tiny sliver of people who made the clinical trial. It would be really valuable to understand what the outcomes of people look like in routine practice, but of course there's never the opportunity to be collecting that data on a routine basis.
And so, I mean, 45 and up at the moment, of course, through the data linkages to ED and hospital data, can identify when people go in and their diagnoses and secondary conditions as well, secondary diagnoses. Is that then, could you turn it around and target that cohort, or rather than collect from a completely new group who aren't involved in 45 and up? Because we've got 250,000 people in the study. Can you use those that are there and select the cohorts that are, having their cancer treatment or have been admitted for various other issues?
So I think that sort of answers the question, is that, how many people with, cohort X do you actually have in the sample? Because some of the conditions we're talking about are, 1 in 10,000, 1 in 10,000, 1 in 30,000 Australians. So they're generally rare, but they're extremely high cost.
And how many samples do you need to have value from research like that? When that's whatever research you had in mind.
Ideally we'll be looking for, a relatively broad approach of the population. It's certainly a question that Martin and I sort of talked about on the back of we didn't even talk about it on the back of an envelope. It was just an elevator discussion about whether or not it would be even conceivable to implement new studies within the 45 and up framework.
So team, if people are interested in a particular cohort, just even feasibility, you want to do a study, but you don't know if we've got the sample size, contact us and we'll run some numbers and say, okay, this is how many people we've got. And that then means that you can start thinking about, is that possible to use 45 and up? And then, you can go out to those people and invite them into a sub-study. Whether we go on to collect other groups, that's something we need to talk about more. But certainly we need to run numbers and check if we've got the numbers that might work for you in your study.
So, for example, one of the cancers that I'm responsible for, you probably only have 8 people in the 250,000. So, but each one of those people, I'm going to be facing choices of several $100,000 a year in spending for each of those patients. So we'd really like to know if the money that taxpayers are paying for these treatments is actually delivering the results that we expected.
Happy to discuss that more. So that it's a really important question.
Kerrin, Kerrin, I had just a couple of questions. I think so 45 and up has contributed patients towards the medical genome reference. Yeah. I guess I've used that in our research as, a control population to compare, variant frequencies in a test population to a control. And I guess I just sort of had a question about one of the things that we needed to do was do sort of ancestry matching in order to, compare sort of apples with apples, if you like. I was wondering, has there been any analysis within the Sachs Institute as to whether people's self-reported ancestry corresponds to their genomic ancestry? Has that kind of thing been done?
No, I haven't seen that at all. But
it's interesting, just as a way of, I don't know what, you know, I suppose it just sort of raises the issue around self-reported data. Of course, some things can't be confirmed, but some things can. My other question was kind of around the anxiety question. So clearly that's something I think anecdotally that's rising, you know, enormously within the community, and wondering whether there are plans to, you know, look at people who weren't anxious prior to COVID but are now anxious in response to COVID, to look at predictors for COVID-related anxiety, which seems like a very topical thing to investigate at the moment.
Yes, it did. We are looking. That's actually been discussed recently, because we're about to go out with rolling surveys, which will be fast and furious. So 6 to 8 week turnaround from getting the questions and the ethics approved to getting it out there and getting the results back. So and displaying, you know, presenting the results. So we're currently in discussions with lots and lots and lots of different groups, all the emergency operations groups and the clinical councils and various others in the ministry and ACI, to identify key questions to add into those rolling surveys. That issue around anxiety and, you know, has there been a tipping point? Can you predict the ones that have become people who become more anxious with COVID or not, and then needing help? They've sort of gone from being mild, manageable to actually now high levels of anxiety and dysfunction. So that's definitely something we want to look at with these rolling questionnaires, and the 85,000 that we just did too, because they've got lots of new anxiety and other mental health questions in them.
Yeah, thank you. That does sound like you've got a great opportunity to investigate that. Yeah,
and I'm sorry I didn't mention the MGRP before, the Medical Genome Reference Bank. So 45 and up contributed by samples to that, and they're fully whole genome sequenced, and that was along with the ASPRI study. So that is accessible for researchers. I have to say, I started in March, and there are things that I'm only just learning about the biospecimens. So.
Yeah, look, that's fine. I mean, I think it's just because I've used it that I was aware of it, and then you know, actually while you were talking, I looked up and realised, oh yeah, that came from 45 and up. I mean, no surprise, of course it would. Yeah. But yeah, no, it's interesting to sort of see these connections.
And that's great to have that as a control group. So they're people with no cancer, no diabetes, and no dementia at baseline. And it's, I think there are about 1,000 bloods came from 45 and up. And I don't remember how many from the ASPRI study. But anyway, that is whole genome sequence data that is accessible for researchers, and that's held at the Garvan, and organised by the Garvan.
Yeah, and there's no cost associated with accessing that data as well, which is great. Does anyone else have a question or a comment about, you know, priorities for future collections? Barriers.
One of the barriers that's been mentioned to me is the sort of gap between basic science and the skill set with basic science and epidemiological analytical skills. And that is a bit of a barrier using an epi study, a population health study, when you've got the basic science skills. So I have been thinking about how we might bring people together, so, you know, someone with epi skills can support someone with the basic science skills. Just happy to hear ideas on that.
I think that's happening more in genomics, like that's becoming now routine, because you really need those, you know, different skills. You need people with epidemiological knowledge to understand, you know, questions that might be worth asking in a sort of population setting. But then you also need people at the other end who understand genomics and, you know, bioinformatics and the analysis of that. But I think quite a lot of those kind of teams are assembling because both sides of that equation realise that they need the other side. You know, it's fairly, I mean, I think there are probably people that are sort of training in molecular epidemiology, but that's still a bit of an emerging field. So I kind of think of that as about just assembling the right teams and people recognising that they need the other side, the expertise that they don't have.
we're happy to, we're just at the moment, we've had a cardiovascular disease research opportunity, and that's to access a place in the 45 and up data, and so a space in the shore workspace, sorry, a shore workspace, and access to 45 and up data, and that closes today at midnight if anyone wants a last minute stab at that. So there's five opportunities there to get a license to use the data, and someone had called and they wanted to do some cardiovascular but with biospecimens, and that they were talking to me about that barrier between epi and basic science, but you know, that's so there. I think that's great that it's happening more, but we're happy to talk and put people in contact with others, which was what we've been doing with this opportunity here, because it was actually New South Wales Cardiovascular Research Network opportunity. So that was for New South Wales researchers. But what we did there was put people in touch. So if someone had a great idea from Queensland, put them in touch with people from New South Wales to increase that collaboration. So
yeah, that's great.
That if people need help and we can reach out to others to help you.
So are you looking for other kinds of ideas for similar sorts of initiatives, you know?
Yeah, happy.
Yeah.
Yep.
I mean, if you've got those kinds of opportunities, certainly the Biobank's happy to help advertise those through our website, and, you know, through our, so please let us know.
Right.
We can definitely
okay, that's great.
Yeah. Anyone else got any
populations to prioritise? Like Craig mentioned, the rare cancers, and are there other populations that are really important that we should be thinking about, and maybe oversampling when we do our next biospecimens collection?
Well, Kerrin, that's just important to me, so we should take that with a grain of salt. But you know, there's lots of, you know, we're finding, you know, we've found that there's lots of things that are important to society that we've sort of been ignoring, and you know, infectious diseases, for example, suddenly is really important. So it's really hard to predict what would be of value, but I guess the sort of the thesis that I was coming from was that the way we are trying to support the biobank and get people to conceptualize the biobank is that, you know, we would be really great. It'd be really great to collect biospecimens for a specific project, but also then make them available for future projects with, you know, some form of searchability, such that every biospecimen gets to be used more than once. Because I don't know about research assets like 45 and up, but biobanks have traditionally been low utilization projects. So, you know, you're lucky if 10% of what you collect gets used. So if we're thinking of, you know, projects that are really important to specific individuals, that they use 100% of the data for their project, but then the data lives on and is able to be used for other cohorts, because, you know, the person with a particular cancer also happens to live in Coogee, and you wanted to compare Coogee versus, you know, somewhere else. So that's the thinking. It does require then you know, quite a bit of social engineering, which is what we've tried to do with the policies and influence the policies that OHMR has helped us with the toolkit. So an open access. So, you know, if you're getting a leg up to collect for a research asset, you must be prepared to share that information into the future. No arguing, no extorting for extra money, no squabbling over authorship. Actually, you know, doing the right thing.
Certainly sounds exactly what I'm hoping we do or will do. So this is still very new with 45 and up, but I mean, I would see that as the intention. But I'd like to talk to you maybe more about that as we move forward. Yeah.
Oh,
I
this
guess
is Sorry, I'm just going to ask a question. It's Jane Carpenter. I was just wondered if you had ethics approval to collect multi-generational information, so from the 45 and up cohort, particularly for genomics, can you get from the pedigrees, you know, their children and their grandchildren, etc., or is it outside genetics?
Currently, it's just the cohort, and they've been followed through the same cohort. It hasn't changed. As part of those discussions about extending the cohort, there have been discussions about, do we go for a different group, you know, the children or the grandchildren. I'm sorry, I couldn't hear very well. It was a bit fuzzy, that. So I don't know if I answered your question or not, but we haven't.
Yeah, it does. It's just particularly in the genomic area that we're in now, which wasn't as intense when the 45 and up first started. I think that there could be interest in those kinds of cohorts.
Yes.
Yeah. Well, thank you.
Thank you. Any other questions?
Yeah, any other questions? I guess, Kerrin, just maybe one last comment that I'd make in terms of recruitment. I think people, you know, I think everybody kind of knows that health research is biased tremendously towards certain kinds of people, and particularly people with, you know, sort of socioeconomic disadvantage are, you know, underrepresented in probably, you know, in many studies. So that seems like something that's very valuable about the 45 and up cohort.
I think you're right, and it's not just, you know, it might not be as a percentage, they still might be underrepresented, but there's such large numbers, and by oversampling older and rural remote areas, then that's actually increased that sample, even if the number of responses were low, if you know what I mean. So certainly large cohorts of those usually underrepresented groups that can be used for research and can want to be involved in research. And I think that's another key thing with 45 and up. There's such dedicated participants. I mean, it's just fantastic. So it's nice. I mean, of course, getting high response rates these days is really difficult, and getting people involved and having to troop out to a clinic and donate blood is really challenging. So especially during the time of COVID, but just generally with traffic and parking and busyness, although maybe that's less so during COVID. So it's a bit of a balancing act there. But anyway, the participants are very engaged, and it is great to be able to go out to them and create sub-studies, ask them new questions, collect biospecimens, collect biometrics, and bring that back into the resource for use by all researchers.
Yeah, no, that's great.
No more questions from me, just thank you.
Yes, look, we've still got a couple of minutes if anyone wants to jump in with a last question. Look, I think otherwise, Kerrin, that was a great talk. Thank you very much for a really informative introduction to 45 and up, and we certainly appreciate, Biobank certainly very much appreciates our partnership with 45 and up, and we, you know, want to, you know, strengthen and deepen that over time. So certainly for people like myself that have relatively recently joined Biobank, it's great to learn about 45 and up, and we look forward to talking with you and working with you further.
Thank you.
Thanks very much.
For inviting me, and also thanks. Yeah, thanks to New South Wales Biobank, and also our other sponsors, Cancer Council, Heart Foundation, Department of Community and Justice, and Lifeblood. So thanks, everyone.
Thanks, Kerrin. Thanks a lot. Thanks, everyone, for joining us.